Hey, well, it is an absolute pleasure to be here. And on cue, Jackie, the sun has come out in Hillsborough. So thank you very much. Thank you for the kind introduction. I've seen some familiar faces in the audience, and I do look forward to catching up with colleagues. Just so I know, my audience, how many GPs? Hands up, please. Okay, 80%, thank you. Practice nurses? Very nice. Clinical pharmacists? A couple of you guys there. AMPs? Anybody else I've left out, please forgive me. Who else do we have? Any other roles? PAs? Physician associate. Welcome as well. So this is a talk that's going to be relevant to everyone. And it's about evidence around flozins and incretins in type 2 diabetes. And what I hope to do is talk through some of the evidence around oral therapy, some graphs there, but we'll try and embed the graphs in real practice. I'll talk about a case study and I'll summarize at the end. And I would like some questions. Please do exercise my mind. I'd like to understand your experience of using these drugs, side effects, what do you do, any conundrums, more than happy to discuss that. And here are my disclosures, but I should also say that I am, it's about doing what we can for the patient and working together as primary and secondary care and industry is what kind of drives me. So, this slide is kind of getting old if you've heard me speak before, but I try and compare what the cost is in the Crown Plaza. This year, Natalie, we haven't got the Crown Plaza. We've got Sheffield Wednesday, but in the Crown Plaza, a night in their nice suite is around £200. And the Sheffield dialysis unit, it's about 450. Annual cost 30 to 40k. And Vickers 2, my home, for several weeks a year when I'm doing internal medicine, is 400, 600 pounds per night. So clearly, there is a huge cost implication of ending up in hospital. And when Jackie asked me to do this talk, I think back to a lecture I had in the first year of medical school where the lecturer, he showed this picture from the Royal Brompton Hospital in London. It was called the consumption ward, and there was lots of people who were sick, and there's another ward with polio. Ultimately, if we can get things right for diabetes care with effective therapy, like there has been for polio, like there has been for TB and other infectious diseases, we should prevent dialysis from happening as a complication in people with type 2 and type 1 diabetes. And certainly that's something I aspire to in my own clinical practice. And of course, since my last talk, we've had the 10-year plan. And I think actually the use of this class of medications fits in very well in the 10-year plan because it's community-based care, prevention as opposed to people coming in with complications, and cardiorenal risk mitigation. And when I spoke last, I said, well, there's some shake-ups that are going to happen with NG28 that have happened. I'm not going to touch too much upon them, but Jackie will, and these medications are absolutely front and center in that class of meds. Okay, a little bit of revision. So perhaps another story. So at a very, one of my medical school interviews at a really, really prestigious place, I didn't get the place, but they asked me the question, under ordinary circumstances, how much glucose is excreted in urine? And I thought, what's this going on? And I thought, yeah, I don't know the actual value. And then the gentleman, he took my hand and he drew a graph, and it was 0, 0, 0. And then he said, what happens after this point? And then, of course, I just kind of froze. But the graph then continues up in a linear fashion. And what that person, the admissions officer, was trying to prove to me that under ordinary circumstances, no glucose should be excreted in urine because the body recognizes glucose as an important fuel and holds on to it. And the sodium glucose co-transporters do the heavy lifting here, 2 and 1. We've realized that actually you can play on disease pathophysiology, and if you block these, mainly 2, because that does most of the reabsorption, you get rid of glucose in the urine. That means you improve your hemoglobin A1C, you reduce fluid retention, so you improve your blood pressure, and it has a huge range of effects on the heart and the kidney that I'd like to talk to you about over the next few slides. So these were the drugs, but actually the only one that should matter is dapagliflozin, right? Because it's much, much cheaper now compared to the other class, and as I hope to prove to you, the evidence is almost identical as the class effect. So I would urge you that if you have patients not on dapagliflozin, to strongly consider switching them to dapagliflozin, unless there are some really strong reasons, and I'll be happy to discuss what they may be with you. Okay, so for your CPD, takeaway points: A1C reduction, 5 to 9 millimolar, weight around about 2 kilos, but in some people I've seen weight loss up to 9 kilograms. And of course, because you're pulling away water, 2 to 5 millimeter systolic and 1 to 2 millimeter diastolic reduction. So that's great. But the real benefit comes in the future when you reduce cardiovascular risk. And the EMPA-REG trial was one of the key trials. So on the x-axis, months; on the y-axis, number of bad events, people dying from heart attacks and strokes. What is really fascinating to me is that, as I say, the alligator's mouth starts to open up at 3 months and the curves really start to change. Empagliflozin has a much lower risk reduction, and that's the relative reduction from 100 to 0.86 hazard ratio, and the same for deaths from cardiovascular cause. And again, that's was shown in Canvas trial with canagliflozin. We don't use it that much because early on there was a signal that cana is not so good with people who have diabetic foot ulcers and peripheral arterial disease, but later on that was felt to just be a signal and not really something causal. And DAPA. Now, the interesting thing about DAPA, when it first came out, it didn't show a huge amount of benefit when it came to MACE, that is major adverse cardiovascular events. So when they gave half the people the placebo and the other half DAPA, they found that those who were at risk of cardiovascular disease had some reduction, but it wasn't that profound. But if you look at the trial, people in this trial, the TIMI 58, didn't have that much cardiovascular disease to begin with. So if you don't have that much disease to begin with, any medication is going to struggle to reduce the risk. So that was one of the key limitations of this trial. But overall, ladies and gentlemen, if you look at it, and this is in nearly 50,000 people from 5 trials, 2/3 of which had cardiovascular disease and all of whom had type 2 diabetes, there is a nice reduction in cardiovascular risk. EMPA-REG, Canvas, Vertus, Credence, and indeed a signal was seen for reduction of hospitalizations for heart failure. Now, the investigators didn't go out looking for this, but the FDA mandated in the late 2010s, well, if you do a trial, you must look at cardiovascular outcomes, and part of that is heart failure hospitalization. So the manufacturers thought, hold on a minute, not only are people less likely to die from heart attacks and strokes, they're also having less hospitalization for heart failure. So let's do some specific trials looking at that. And indeed, DAPA and EMPA had these trials across the ejection fraction. And again, they showed benefit in reducing hospitalizations from heart failure. And then there was another signal seen for the kidney. So we've talked about improvement in A1C, talked about blood pressure improvement, reduction in cardiovascular risk, and a signal for improvement in kidney function. So DAPA-CKD specifically looked at, well, what happens when you randomize people who have type 2 diabetes, and we give them this medication to look at what happens to their EGFR and whether they end up on dialysis or need a transplant. And again, a very nice opening up of the curves with people randomized to DAPA in blue, and happens really early on, 4 months. That's really quite something. So the relative risk reduction is important, but see, numbers needed to treat, and you'll remember it's a formula, it's 1 divided by absolute risk reduction, and that numbers needed to treat is in the 20s for this, which is really impressive. Depending on people treated, 1 is less likely to end up with those bad outcomes. EMPA then showed exactly the same, again arguing for a class effect and a very similar time frame. Okay, so lots of benefits. How does it happen? The truth is, I don't think we fully know, but there are multiple. If you have any slide in a research paper with so many mechanisms, the answer is no one really knows. But the way I rationalize it and think about it in a clinical way is that you're losing glucose, fantastic. That changes the pressure in the kidney, that protects the kidney in a way, the intraglomerular filtration pressure. You'll remember that ACE inhibitors and ARBs do that as well. You're taking away some water, that helps the heart. You are also improving glycemia. And an interesting thing, you may see this. I had a patient who was on eflozin and they had heart failure, and then, their hemoglobin was improving slowly. And I thought, well, what's going on here? Your hemoglobin has been 9 for years. And it turns out when your kidneys start to get better, they start to make erythropoietin, which gives your red blood cells a kick. You start to make more hemoglobin, and that means you're less breathless and your heart failure also improves. So multiple mechanisms. Also, these drugs, the body thinks you're in a state of starvation, so it starts to make ketones. So if all of us without diabetes started to take dapagliflozin for, I would say, 2 weeks at 10 milligrams, and we decided to check your blood ketones, I would argue our ketones would be around 0.6 to 0.7 millimoles per liter. That would be normal, because the body is losing glucose, it's thinking that's in a state of starvation, it is making ketones. And there is some thought that the ketones, in and of themselves, can also help protect the heart. But of course, that generation of ketones can lead to a side effect, which we'll also cover in the latter part of my talk. So a few of us got together and thought, well, how do we use this now? We've got this rich evidence. How do we put this all together? So these are our guidelines in Sheffield Teaching Hospital. So we say the buckets are diabetes, cardiology, and nephrology. So if you've got diagnosis of type 2 and you're at high risk or of cardiovascular disease, or you've got established disease, you ought to be on it. If you've got reduced or preserved ejection fraction with heart failure, you ought to be on it. And then nephrology, we go down to DAPA and EMPA, but we updated that now to just stick to DAPA with microalbumin leak in the presence of diabetes, or in the absence of diabetes as well. So if you've got type 2 diabetes and you have more than 3 milligrams per millimole creatinine leak, you ought to be on it. And if there's no type 2 diabetes, that 22.6 milligrams per millimole creatinine. That 0.6 comes from conversion from American units, which is why it's that precise. Okay, so we've discussed the SGLT2 class. I hope I've convinced you that they have profound benefits on glycemia, but mainly the cardiorenal protection, which is independent of glucose, is really impressive across a range of medications, across a range of patients. The absolute evidence is very similar for all of the drugs, so I'd urge you to consider dapagliflozin. The next class of meds, which have been really interesting, is the GLP-1. So these meds weren't basically available when I graduated. I think the first time I came across one was in Rotherham District General Hospital when one of the patients was on them, and I'd seen them in a clinic. We used to do clinics then as ST1s. They had quite a lot of weight and saw them, and they looked completely different. They walked in, new wardrobe. It was a summer. They looked really happy, and I said, "Well, what happened?" And this person said, "Well, I've started this new injection. It's called exenatide, and it's changed my life." So that got me really interested in how these things actually work. I ask the medical students this when I give the annual lecture to them on diabetes meds. So say, for example, that you have 2 people, and you give them the same amount of glucose. One person, you give the glucose orally as a drink, and the other person, you give the same amount of glucose as an injection into the vein. Out of these two, who is more likely to make more insulin? Now, if you think about it intuitively, you think, well, if it's going through into the intravenous route, that's going to be quicker, right? Quicker. So probably they'll make more insulin in response to glucose load. But in actual fact, it's those that take the glucose orally. So that is known as the incretin effect, and that's demonstrated in this graph. When you take the load of glucose orally, you start to release hormones from the gut, the GLP-1 being chief amongst them. And that does 3 things. It makes you feel fuller quicker. It gives your pancreas a bit of a kick to make more insulin. And it also tells your brain it's time to stop eating. And really, the pathophysiology of these drugs and their benefits rests upon those 3 things. The Gila monster is where this was initially, there's a nice story around how these drugs were discovered. Around 20 years of hard work in labs in the US, and a guy called Dan Drucker, who does great amounts of sort of social and scientific engagement with people, but he spent like decades in the lab getting nowhere. And then he discovered how rats respond to normal glucose metabolism, and then they were able to genetically codify what GLP-1 was. Then they found the closest equivalent was in an Arizonian desert lizard. Unsurprisingly, they didn't have many participants for their first in-man trial. Since then, we've moved away from this, and we are now not using the Gila monster spit to inject patients, but this is where it all started. So exenatide, my first exposure to that patient in Rotherham all those years ago, and then liraglutide, I remember Jackie telling me about this, so some nice cardiovascular data, we were using it. I haven't used exenatide. Dulaglutide I was familiar with, and semaglutide has an oral combination as well. So these are the GLP-1s. Okay, they had good reduction in A1C. You lose weight, modest 2 to 6. Actually, in real life, I've seen people lose up to 10 to 15% of their body weight should they stick to these meds for 6 months. And also, if you are less big, you lose weight, your blood pressure improves. So, bit more trial data. Liraglutide. The good thing about liraglutide is it was first to show that in addition to weight loss, you reduce cardiovascular risk within 6 months. And that then made us think, well, if the flozins reduce cardiovascular risk, maybe these drugs, the GLP-1s, also have benefits outside diabetes and the heart. So the FLOW trial is, I think, it's got great evidence for semaglutide, and it was semaglutide or Ozempic, 1 milligram versus placebo. The investigators were looking at what happens to renal function. Are they likely to end up on a renal bed or die or have dialysis? They followed people up for nearly 3.5 years, and they found that semaglutide reduced all of these outcomes quite impressively. And the cardiovascular benefits are, again, a bit like the flozins all across the class. Okay. When people compared flozins versus GLP-1, which I think is an important comparison, they found similar benefits with all the drugs. But actually, when I kind of really sat down a few months ago and started to put this together in my mind and think, okay, so you've got a patient sat in front of you, and they've got, some cardiovascular risk. What are you going to go for? So for a flozin, you have an 11 to 12% reduction in major adverse cardiovascular events. Very similar with the GLP-1s. Heart failure, I think the flozin has slightly better evidence, but the newer GLP-1s have more vigorous evidence for that. I'll come to that, like tirzepatide. In terms of kidney disease, I think that the weight is fairly equal, but I still favor flozins because of their very, very strong data in that. And that holds true for ending up on dialysis transplant or dialysis or transplant waiting lists. I think the FLOW trials has really pushed the evidence in favor of GLP-1s for that. Okay, so we move on. And now we move on to dual GLP GIP. So far I've talked about GLP-1. Now this is dual agonism. We're kicking two parts of the incretin axis. So the main example of this is tirzepatide or Mounjaro in our clinical practice. So how do they work? Well, they do pretty much the same. It's a bit like you supercharge it. You eat less, you improve your glucose, slow down gastric emptying, give the beta cells a kick to make more insulin. And another advantage I think of tirzepatide is I've seen a lot of people's triglycerides improve. It does sort of suck up and mop up some of the lipids, which is an additional benefit. And in SURPASS 2, where tirzepatide was compared to semaglutide, we found that both drugs actually do a great job in reducing weight and hemoglobin A1C, but tirzepatide was superior in a way. It was non-inferior certainly, but I think it was superior to semaglutide at 5, 10, 15 milligrams compared to semaglutide 1 milligram. And that makes sense biologically because you're kicking at two parts of the incretin axis. So, as I was preparing for this, I thought, why don't I summarize some of the data for both, because there are these two things that are available to us. I think when it comes to weight and glycemic effects, there is more weight loss with tirzepatide, and that's from the SURMOUNT-5 trial. There's also an improvement in glycemia, tirzepatide, 2.30% A1C versus 1.86. 1.86 is great, by the way. Higher responder rates for significant weight loss. That is more than 20% is a definition for significant, nearly half of people on tirzepatide. But when it comes to cardiovascular evidence, I think semaglutide, by nature of the fact that it's been around a bit longer, has some very, very strong cardiovascular protection data from SELECT and SUSTAIN-6. Tirzepatide was non-inferior to dulaglutide. It was dulaglutide that was a comparator in its cardiovascular trial. So it does do better when compared to dulaglutide, but it wasn't compared head-to-head to semaglutide in cardiovascular endpoints. Both have similar side effect profiles, and we'll discuss them shortly. So all in all, I think both drugs are great. They both help patients. The weight loss and glycemic benefits at the moment, in light of the evidence, are superior for tirzepatide. Semaglutide has some great evidence for cardiovascular protection, and in my view, through the FLOW trial, for renal protection as well. Okay, this is the important slide. So, side effects. Flozins. One of the most common things people get is genital infections, UTIs, fungal infections. If people are frail, they can end up with postural hypertension. The one that we worry about is euglycemic diabetic ketoacidosis. So when I counsel people to a Flozin, I say, look, this is a really effective medication. It's going to help your diabetes, but also protect your heart and your kidneys. But like all medications, there are some side effects, I'm afraid, and I don't expect them to happen, but I'd like to counsel you so you know what to do in case they happen. And I go through the UTI and I talk about hygiene and so forth and to let us know. But the one I counsel them to specifically is euglycemic decay. I say, well, the medicine works by pulling out glucose through your urine, and your body thinks that it's in a state of fasting, really. So, your blood can become acid if you're unwell. So if you're unwell for any reason, stop taking the medication and only restart if you're eating and drinking and well. And I have to say, for most patients, we've not had, if you're counseled properly and they're sensible and you've chosen the person appropriately, they will be absolutely fine. But now and again, we do get people come on the medical take when I'm doing, Easter, Good Friday, I walk in, first patient, euglycemic decay, and they did follow the sick day rules, but they nonetheless ended up in diabetic ketoacidosis. The other thing is if the medication's not stopped sufficiently before hospitalization, for example, elective surgery, then that can also cause problems. I remember a case many years ago now where someone had a major bowel operation was planned. The Flozin was stopped 1 or 2 days before, but its effects linger on, and the patient ended up in ICU. They were very acidotic. The people were chasing other causes of acidemia after surgery, like is this anastomotic leak, is part of the bowel died. But then one of the really bright F1s on ICU said, oh, why don't we check ketones? This person's on a drug called Flozin, and ketones were like above 6. And they were treated and they made a good recovery. So what about the GLP-1 GIP? So when I counsel people to this, again, I say how the drug works. It makes you feel fuller quicker. It tells your brain to stop eating. You will feel full up on it. One of my patients, I had to negotiate with them recently. They were going on an all-inclusive to Antalya, and they're like, there's no way I'm starting this before my holidays, so you have to do it. I said, well, okay, fair enough. So we just started after their all-inclusive trip. So by virtue of the fact that if there is fatty food, if you eat fatty food, it's going to hang around longer. So we do counsel our patients to that before starting it. We say, well, you'll get more side effects if you have fatty food on this because the food's going to hang around longer. I say common, and I use what I mean by common is more than 1 in 10%, 1 in 10 people, 10% or more. Very common is even more, up to 50%. So nausea, vomiting, mild abdominal pain, cramps, that can happen, constipation or diarrhea, especially after fatty foods. Weight loss will happen, that's normal. Pancreatitis, this is an interesting one. Now I've really kind of nerded out and gone through the original studies because I wanted to give my patients a realistic number when I counsel them in clinic. And the totality of the evidence so far suggests that it's 0.3 to 1% risk of pancreatitis. That's in clinical trials, though, in big centers where people are calling up the research nurse or a research fellow or someone like me who's seeing them day in, day out when they come for their visits. In the real world, I don't think we actually know. We know that there's nearly 2 million people plus on these medications, and we're not seeing lots of people coming through the northern, but we do see cases of acute pancreatitis. And then it's a question of cause and effect. Is it the drug, or is it the fact that they have obesity and gallstones and other risk factors? Usually, if it's the medication, no obvious cause is found. When we scan their tummy, there's no gallstones there, their lipids are not through the roof, and then we think, well, could this just be the drug? So I do counsel them to that 1% risk. There is an increased risk of gallstone formation. If you drop your glucose very rapidly from a high level to a relatively normal level, your eyes don't like it. This is called early worsening of diabetic retinopathy. We've seen this for years, for decades. There was a signal with this early on. We haven't seen that in some local analyses that we've done, but I think we have to be a little bit careful when people have a very, very high glucose level. Hypoglycemia is only an issue if someone else is, the patient's on insulin or a glycoside. If they're not on those other drugs, it's less of an issue. So these are some of the side effects. The one I should really bring to your attention, though, and I'll talk about this in my counseling tips as well, when you lose weight, you just don't lose weight with the GLP-1 class, particularly at the higher doses. Patients will lose muscle mass as well, a condition called sarcopenia. So that is something I think we need to be really cautious and cognizant about, because if you lose muscle, it's hard to bring it back up. And this is what was happening last year. The MHRA are conducting a study, still ongoing, around actually who gets pancreatitis from this class of medications. There was a sad case in Edinburgh where a nurse died. It wasn't, clear there was cause and effect for the reasons I've discussed, but there's a study ongoing, and I hope that the next PLI will be able to give you a bit of an understanding as to what is the phenotype, who is it that is at risk of pancreatitis with this class of drugs when this study reports. Okay, top counseling points for all of you colleagues when you see patients. It is important to recognize that people will drink a lot more water and feel thirsty. Thrush is common. Identify and treat it. Know the sick day rules. I give patients a leaflet we've developed before they leave, or send it with my letter. There is a risk of volume depletions. Have to be careful, particularly in older people. Hypoglycemia is less of a risk unless someone's on a GLP or insulin. In that case, what I normally do is I basically halve the dose of the GLP, and if they're on a GLP and insulin, I pull back on the basal insulin by 10 to 20%. For the GLP-GIP, nausea is common. Small meals, start slow, and we go up slowly with the dose. There is an increased risk of pancreatitis and gallstones, and in terms of contraception, I think it's really important that they are on a secure form of contraception, because if they're on a pill, it's probably best to have a barrier as well, barrier contraception, whilst you're starting the medication, because if there's nausea, they may vomit the pill, and it's less effective. So dual protection in those times, or when you're going to increase the dose. There's a washout phase of a month, which is about 5 half-lives. The drug lasts roughly a week in the body, so you want it to be out of the system, so you ask them to be off it for at least a month before they start trying. We've had some young ladies lose profound amounts of weight, which would naturally lead to an improvement in their fertility. And I'm always anxious, Jackie, when I walk into clinic thinking, is this person, they're pregnant, are they on tirzepatide? Luckily, touch wood, quickly, we haven't had any cases, but we do counsel patients to this, and I think we should. And I've already talked about malnutrition and sarcopenia. I feel, and I'm interested to hear your thought, I think at the lower doses, this is less of an issue, but certainly at the obesity level doses, this becomes an issue, and we should counsel patients to malnutrition. I ask them to say, look, just get a good multivitamin, and when you go to the gym, please do go to the gym, because the weight will come on if you stop this. And we have these discussions around when should we stop this. You should institute fundamental dietary and lifestyle changes so that we achieve our goal, which in your case with diabetes is a near normalization, if we can, of your glucose levels, but also to protect your heart and kidneys. Now, a patient asked me recently, a young patient, how long do I carry on? Because I look great, I feel fine. He told me the glucose is good because they bring a card, we do a point of care test A1C, it said 37 on it, and they'd been on tirzepatide for a month, and they're about 21 for a year, and they're 21 years old. So tirzepatide for a year, 21, normal hemoglobin A1C. So it's a good question, really. I know that if I stop the tirzepatide, the weight will pile back on within 12 to 18 months. And it was a weight that was driving insulin resistance. So I said to them, look, the evidence says that your weight will come on if we stop this medication. But equally, you are making the point and a convincing argument that you don't want to carry on this forever. So what we can do is we can gradually down titrate and take you off it. But we take a watch and wait approach. And in that time, you must institute dietary and lifestyle changes and prove to us both that we can keep this thing in remission, because we absolutely want to keep this in remission. if this goes back up to the levels of A1C at 75 or 80, then we know from studies that takes away up to 10 years from your life. And my job, my agenda as your physician is to make sure you have a long and healthy life without these side effects and complications. So we're doing that, and so far so good. He's doing well. His A1C's crept up a little bit, 42, but he's 6 months off and he's still in remission. On the other hand, I had a patient who had a fantastic response. They were actually on a Flozin plus tirzepatide and metformin, so triple therapy, but they'd had a heart attack in hospital. They were under my care, and I did a follow-up via telephone with them. Things were stable. They asked me, well, I've done well. Do you think I can stop? And actually in them, I said, I don't think I can stop because you've had a heart attack. The medications, as I've shown you from all those graphs, they're preventing future events. And therefore, if I stop the medication, there's a good chance that the process that caused the heart attack in the first place is going to occur again. But then I heard his voice, but you said the glucose was fine, doctor. And I said, you're absolutely right. The glucose is fine. But the reason why I'm giving these other medications, the tirzepatide and the Flozin, the dapagliflozin, is to reduce future risk of heart attacks, strokes, and to protect the kidneys. So that's my approach to an off-ramp, a question that I often have in my mind. I think we have to be a little bit careful, particularly in our younger patients, around eating disorders. This came out in the New England Journal of Medicine a couple of weeks ago, a few weeks ago. And the author had a nice perspective from their own practice in the United States, in Boston. And they said, look, we are giving lots of people these medications, but actually, I'm worried that we may be inducing some eating disorders. And some patients who have eating disorders may be misusing these medications as well. NICE does speak to this in NG28. It gives a BMI cutoff of less than or equal to 18.5, I think, to stop. But something to bear in mind, particularly in younger patients who have disordered eating. Okay, so I've got a few minutes and I will go through a case study which I hope will anchor in some of the discussion, some of the data that we've had. So I have this gentleman. When I took over this man, he walked in the room and he looked very suspicious of me, and he sat down and first thing says, where's Dr. Scott? I said, Dr. Scott, Adrian was a really great guy, a physician par excellence, as I said in his leaving letter, and a really good man, and I took over many of his patients. So for the first few months, I had to just win patients over, so I thought, I have to work hard with this man. He's had type 2 for 12 years. BMI was 26.9. He had NAFLD already. He had eye disease, and his urine ACR was high. A1C wasn't so bad. He was on ramipril, basal bolus insulin, metformin, 1 gram BD. Okay, this is a question to you. What is the next most appropriate addition of therapy from a cardiorenal metabolic perspective? So just to recap, South Asian chap, 12 years type 2, BMI 26.9. He's got eye disease and urine leak with an A1C of 59 on metformin, ramipril, basal bolus. So all in favor of A, of Flozin, please put up your hand. Okay, very good. And those in favor of GLP, GIP, and injectable, please put up your hand. No one. Okay, that's interesting. I went with the Flozin. My reason for going with the Flozin was embedded in the evidence, which I suspect is what you guys have hinted to as well, is that the predominant risk in this gentleman is his microalbuminuria, and the evidence for that, particularly at that time point, was in favor of a Flozin. Now, if I saw him, actually, I think there's equipoise between a Flozin and semaglutide, because he's also got NAFLD, and the GLP, GIP are very, very good at inducing NAFLD. 5-minute warning. Thank you, Natalie. So here, the proof of the pudding. He came to clinic. This is before. Average glucose 13.7 before the DAPA 10. Next was it 8.9. One hypo, which is really not really a hypo, that little dip right there. And his time in range gone up from 39 to 79. It's fantastic. And I think he finally thought I was half decent compared to Dr. Scott. Still quite a long way to go. This morning, I had to trouble Natalie to put my slides. I made a change at 12:45 p.m. because you may have heard this on Radio 4. and I certainly read it when I woke up this morning. One of the fundamental issues we have is these medications are great, the incretins, they're fantastic, but when you stop them, the weight does come back on. And there are two schools of thought. One, which says obesity is a chronic, lifelong condition, which therefore should be treated with chronic, lifelong medication. Another school of thought thinks that obesity and its complications, a myriad of them, are fundamentally a consequence of societal and governmental failure because of sugar, food, access to high quality food being an issue, particularly in deprived parts of towns up and down this country. And, if there was an investment in public spaces, leisure centres, youth activity programs, obesity wouldn't be a thing. You can take a dogmatic or moralistic view. As a scientist, as a physician, the problem is when we stop the meds, the weight comes back on. So it's interesting to me that this oral compound, which is really difficult to pronounce, orforglipron, I think, which is being produced by a manufacturer in the US, so there's this trial where they took people who were on Manjaro, and they were taking Manjaro, and then they stopped the Manjaro, and they continued on this oral GLP, and they found that these individuals had some weight maintenance. And, it may be that they carry on, but of course, from a local perspective, unless you're on Manjaro to begin with, you're not going to end up on an oral tablet, and we're still some way out from having the tablet license in the UK. It's licensed in 2 countries at the moment, the US and the UAE. So something in terms of that exit strategy or not for your patients on these medications. Okay, so I would like to stop there and summarize. I have shown quite a lot of data slides, but I'd just like you to take away these key messages from those graphs that I've tried to convey to you. These medications absolutely, without any doubt, have cardiorenal benefits independent of glucose. They have impressive results with glucose as well, of course. I think in 2026, what we need to do is risk stratify patients based on cardiovascular, renal risk, their age, particularly if they're less than 40 years of age, and not have inertia in starting medications. If they're on another preparation of eflozin, I think the evidence, as I hope I've showed you, is compelling for DAPA. It's very similar. This is a class effect. And I think we should start these medications early so we can help our patients and hopefully reduce those admissions to the dialysis wing at Northern General. Thank you very much indeed.
Okay, thank you very much. I think we've got time for a couple of quick questions. Okay, first one over there.
I had it's just about a patient came across recently, and it was mentioned that there was quite low risk of hypoglycemia or starting with GLP. There was a young chap who was diagnosed in clinic with HbA1c over 48, and he started on metformin. He then on for Manjaro finally. His BMI was 61, slightly higher before, and he started losing weight. But when he increased up to 1 milligram, he started getting postprandial hyperglycemia, even though he switched to a diet like low glycemic index foods, which are going to drop about 2 millimoles or in that region. We've referred him in, and the Reg said something interesting that they've come across these cases of postprandial hyperglycemia where people who are losing weight become more prevalent. They're more sensitive to change. I just wanted to come across any more of these cases.
Thank you. I'll summarize the question. So the question is on use of semaglutide up to 1 milligram in a man with a BMI of 51, developing postprandial hypos despite dietary advice, correct? Personally, I have seen 1 or 2 cases. My approach is I corroborate the hypo because it's normally picked up on the sensor and ask them if they're symptomatic, and we finger prick. If it is genuine and the 2 match up, if they've had the dietary advice, we pull back on the dose, and we pull back on insulin mimetics if they're on it. Were they on any other medications?
He was on metformin.
You stopped everything. Yeah, you stopped that. So it can happen because remember you're giving insulin a kick, and you're also delaying gastric emptying. So the approach there really is to pull down back. I'd go up down to 0.5 milligrams and see if that helps. And if not, up to 0.25. But there will be a subset of people who will have these issues, sadly. Sometimes it's whether they're actually keeping to the dietary plan as well, and if they're really enacting that in real life. But yeah, thank you. That's my approach. How did you do? What did you do with it there?
Well, he'd only had 2 HbA1c, so we wanted a bit more investigation anyway.
Fine.
But we stepped down to 0.5. We actually stopped it and the metformin and gave him a freestyle lever. And we're still getting high dose.
Okay, so that's interesting. So I think we need to ask the question: is it truly the medication that's culprit there? But yeah, great question.
One more question.
Triple therapy, SGLT2, and you kept everything the same. Well, what is the rationale for maybe keeping the metformin? Discuss the risk reduction benefits. Because I think the relay section of 2 drugs, but why would we keep metformin, or do we just stop it when the agent?
Great question. Nice seem to be obsessed with modified release metformin, don't they? It's everywhere. Actually, I saw a paper last week, still debating how metformin actually works. I don't think we actually know how it works. But what we do know is that in very, very large cohorts, there's a signal to slightly reduce cardiovascular risk and have slightly better liver outcomes. So my question would be, if the patient's tolerating it, there may be benefit, and I wouldn't upset the apple cart. There isn't convincing cardiorenal specific evidence for metformin. Yeah. But if they had any side effects, I'll certainly stop it.
Good. So can we just thank Dr. Iqbal again? He'll be here for the break.
I'll stay.
Yep, so it's going to be here during the break.